Hi, everyone. My name is Michael Brock. I am a product manager and education lead at Precision OS, and I'm welcoming you here to the fourth episode of our virtual reality podcast, which we are now calling our virtual grand rounds. The aim of this podcast is to educate residents and surgeons who are interested in specific topics around what's available in virtual reality to practice. And I'm really excited on this episode to announce that we have a new feature coming out called our Case Spotlight, which is going to give an open and free, accessible virtual reality surgical case to anyone that wants to access it on a regular cadence. And Danny, I'm going to pass over to you for a bit of an introduction, and maybe you can share what we're hoping to do with this virtual reality podcast by inviting key expert surgeons to
Yeah,
subsequent
great.
episodes.
Great, Mike. Thank you so much. My name is Danny Coyle. I'm an orthopedic surgeon and CEO and one of the founders of Precision OS. Grand rounds, as many of you know, is a tradition that medicine has had for decades, if not longer. And what it involves is you invite a guest surgeon and they share their expertise and their knowledge and their wisdom with the audience, which is usually a very coveted and, as mentioned, sort of heartfelt tradition that lives in medicine and has been there for quite some time. One of the things we wanted to do with this virtual grand rounds is bring life to that expert knowledge. So, for example, a surgeon who's an expert in pelvic and acetabular fractures or ankle fractures comes on this podcast, he or she would share their wisdom with a case. And then we want people to actually be able to go into that case in virtual reality and do the exact same procedure that that surgeon just described while comparing their data to what they think would be appropriate. And then, of course, the watch practice in VR, and then the ultimate would be to actually go ahead and perform a procedure of similar type on your patient. So we wanted to bring it all to life, and that's what we're excited about today with this first episode of the virtual Grand Rounds.
Fantastic. And I think it's a great kickoff. What we're going to show today is the first freely available case, which is available now. If you want to access it and you're watching this, all you have to do is go to our website, precisionostech.com, and sign up for a free trial. And going on in perpetuity, you'll have a free case at a regular cadence that will be, as we're doing today, described and showcased to you with some explanation and expert insights so that you can train and grow from it. So our current case spotlight is a fibula fracture. It's going to be a transverse fracture, and I'm going to go into VR right now. And Danny, you and I can work together on the skills here and what a resident should really be learning and growing from in doing this
Perfect.
practice opportunity.
Yeah, let's do it, Mike.
Okay. All right. So this is the spotlight case that we have upcoming for our fibula fracture, where we have a virtual patient set up supine. The lower extremity is able to be moved and manipulated to your heart's content, and we can work through this transverse fibula fracture. So I'm going to pull the bone out of the body to visualize it more directly. And then, Danny, I'm going to probe you with a question here. As a resident, what should I be considering with the anatomy related to the fibula and the tools available to me in this application to really get the most out of this skills practice opportunity?
Right. I think the first thing to think about, Mike, before we talk about the fracture is how is the patient positioned? There's a couple of subtle details that you have in that operating room, which I think are worth noting. The first is the arm position, where it is right now. You could consider putting that into a T across the chest, although this position here is fine as well. You just have to make sure it's supported and it doesn't fall off the side of the bed. When we come down to the limb, you have a black cushion there, which I think is a really nice feature because that elevates the ankle and allows you to not be right next to the operating room bed when you're putting a plate and screws through the fibula. The second thing about that is it allows you to internally rotate the leg because you'll remember the fibula is a somewhat of a posterior structure. So if you were to internally rotate the leg, and I see what you're doing there, which is turning the skin off, and you've got the bones exposed now. So look what happens when you internally rotate the leg is a fibula becomes much more horizontal to the floor. And what that allows you to do then is you can just use your finger to demonstrate it, but if your finger was the drill, you're actually now parallel to the floor as opposed to if you externally rotate the limb when you're fixing the fibula, you can see where the orientation of your hand would go from inferior to superior, which is not ideal. It becomes ergonomically quite challenging. But From a patient setup, I think those are some critical points that I would pay attention to for any fibular fracture.
Fantastic.
The next part, of course, and then we can go on to the next step, is the C-arm position is, I think, ideal. It's across the body, it's on the contralateral side, and it's going to allow you to take AP, mortise, and lateral views of the ankle. So I think that overall that position and setup is quite good.
Now, when speaking about the imaging, in the application, we have live fluoro. So, as a resident, training and getting an understanding for that sort of three-dimensional 2D translation of understanding anatomy, what do you think a resident should really be gleaning from this? What should they focus in on to sort of get the most out of this skills training opportunity? Keeping in mind that you can also take individual shots sort of at a lateral position at any time you want as well. So, if you were to think back to your years of training and residency, what might this opportunity afford you to build knowledge and understanding?
Regarding imaging, Mike, I think it's a really good question. And some things to consider when we have intraoperative imaging is orthogonal views. Being able to get both an AP and lateral is critical to any type of fracture fixation. Now, when we think of the fibula, one of the things you want to consider is a general principle, I guess, in all fractures is you want to make sure you restore length, rotation, and alignment. And if you know what a normal X-ray looks like of the ankle, you'll be able to discern if there's shortening of the fibula. And so in this case, you can see that as you rotate, you can see where the clear space along the talus, there's an area distal to the fibular tip, which aligns with the lateral part of the talus, which I think you can consider. And those little nuances, and I'm not a foot and ankle surgeon, so when we do have our virtual grand rounds with our first foot and ankle professor, we're going to get into more detail about this. But generally speaking, that mortise view and then looking on the lateral helps you ensure that you've established length, rotation, and alignment.
Amazing. So let's continue on in this case so we can show everyone who's watching what they're going to actually be able to practice. In this first step, the real setup here is understanding patient positioning, understanding sort of the characteristics of the fracture you're going to be working on. And as we transition into later steps of the case, step two gives us access to a wire driver and K-wires. So I'm going to come over here. I'm going to pick up some wires. And I'm going to ask you, as someone who's more novice on this, while I'm positioning a wire, and I'm going to turn the skin back on so that I'm not necessarily seeing directly what I'm doing, I find I take a lot of x-rays and I don't know the correct number I should be taking. I don't know what's considered too much x-ray versus being more skilled and being able to do this quickly. So while I'm positioning my wire here and manipulating my hand to get the orientation correct, I
Yeah.
find myself taking maybe 5 or 6 x-rays per attempt. And I don't know if that's too much. So what would you tell me, as someone who's about to miss the bone
Yeah.
entirely here, what I should really be considering to be more comfortable in using X-ray in that regard?
It's a really intuitive question, Mike. I think I'm glad you asked that. Right now, we don't have a standard for what's normal in the number of X-rays someone should take during any particular case because we have never been able to record that amount of data from a large pool of residents, fellows, or surgeons. Now, when we think of what's the benefit of having intraoperative imaging, it's helping you decide on the position of your implant, but also giving you information about the 3D geometry of your underlying fracture and subsequent skeletal anatomy. Now, being able to decipher what you see on C-arm, creating a mental image of a 3D model, helps you over time take less X-rays because you have a really deep understanding of what you see on the C-arm, and you're able to create that three-dimensional model in your brain really quickly. I think one of the reasons why people take a lot of X-rays is they struggle with, or they may be challenged with having that create that mental 3D model quickly. And this software allows you to really accelerate that skill set.
Yeah, I mean, the more practice I get on the individual bone, because it differs based on what bone I'm working on, the
Yeah,
more comfortable I feel on repetitions that I do. I've
sure.
practiced a lot on sort of medial malleolus cases based on our previous cases that we've released. So I feel
Right.
much more comfortable in wiring that than I do the fibula,
Yeah,
which I mean, it's great to get this opportunity to practice in a different component of the anatomy of the human body because
Yeah.
it really shows that you can't just rely on the skills you build in one case over and over again. You really have to have variety in training.
Yeah, agreed.
So let's continue on here. I'll remove my wire so that it's not in the way. Pull it on out. And then I'll put us forward into plating. So in this case, step 3, we're actually able to pick up plates. Now, in this case, we have a bunch of 1/3 tubular plates. That's what we'll use in this case. And maybe you and I can talk through some of the specifics of what I should be doing when I recognize as a younger resident, I'm probably not the one to be choosing and selecting which plate to use in this case. But when I'm there with my attending and sort of following along, what kind of questions should I be asking them? And what should I be considering at this stage of the surgery to better my knowledge of what's going on?
It's a really good question, Mike, because this is where we get into trying to extract as much knowledge from your mentor as possible. And I think questions that are reasonable here include, what type of, how would you classify this fracture? What type of fixation strategies are options here? And what are we planning to do? As we sort of move into getting our first foot and ankle surgeon here, there's going to be lots to discuss of this fracture. You can plate this fracture. How long should the plate be? I'll be really interested to hear from them on what are the indications for nailing a fibula because you can actually put a nail down or up the canal. These are kind of things that I think are really good for residents to ask their mentors. The other part is, well, how long should the plate be? Since we're talking about plates here, how will you get compression across this fracture given it's so transverse using the plate that you have? And the third part is what are the sequence of screws that you're going to put in based on the fracture type that we see here?
So with that in mind, we're also able to actually put screws in. And so you mentioned before about compression on this fracture.
Mhm. Yeah,
Um, what are some typical strategies that I would use in a fracture? I think this fracture is kind of unique because it's transverse and not
right.
oblique. So um, options probably differ on how you might get compression across this fracture. But what kind of maybe tips or tricks would my attending be using when fixing this or attaching the
Sure.
plate that they might not be as clear to me as a resident because it's so innate in their practice that they don't even think to sort of explain what they're doing in a given time when they're
Yeah,
trying to get some fixation here.
this is going to be a really nice illustration. So go ahead, Mike, and put a screw in the fourth hole from the bottom.
Right here?
That's correct. Yeah. So
Okay.
that's a
And I
part
want
of
it
the fracture.
perpendicular to my plate, I'm assuming?
Yeah. So you want to be not only perpendicular to plates, you want to be ensuring that your screw goes through both cortices of the fibula.
Okay.
So
Let me
don't
drill.
skive, don't be too superior or too inferior. And I want you to make sure you're listening for the sound of the drill because it's going to change whether or not you're in cortical or cancellous bone, and then see how it feels as well. I mean, that's an excellent shot. It's a perfect screw for that fibula because you see how thin it is.
Yeah. Not a
And
thick
now,
bone.
yeah, so things to pay attention to here. Does the drill change in its sound that it makes, the pitch? What does it feel like? Because in those controllers, you can feel the difference between cortical and cancellous bone.
Yep.
And then, of course, you've created a hole in bone, which gives that visual feedback. Now, if I was going to get compression, Mike, across this plate, one of the things you want to do is go ahead and take your drill and you want to put the drill in the third hole from the bottom, but you want to put it, if you can zoom in, you want to put this hole or this, you want to put your drill bit as close to the inferior part of the plate as possible. Yeah, so no, maybe not that angle, but you want to be right against that part of the
I see what you're saying.
yeah,
I'm going to use this needle to sort of illustrate what you're talking
yeah,
about.
please, yeah.
So you're saying that you want this screw to go on the inferior edge of
Yes.
this third
Yeah.
hole from the inferior side.
Yeah,
And
because if you
why would that help?
so if you did that and you went ahead and drilled your hole and put your screw down, what direction, you can use the marker to illustrate this, but what
Sure.
direction would that plate go after you put the screw in?
if I put it on this sort of inferior edge of the third hole, my intuition is telling me that it's probably going to pull the top edge down to sort of
Right, right,
pull the plate together a bit.
right. And what that'll do is that'll compress the fracture because you already have a fixed point above the fracture.
Okay, that makes sense.
Yeah.
So let's put that screw in, focused on trying to get it on that edge as best I can. And I can hear the sound and pitch change as I'm going through both cortices, and the haptics are giving me that feedback too. So there we go, bicortical.
Now, Mike, why don't you show us how easy it is to actually skive on the more
Well, that's my
frontal or the
specialty.
volar and dorsal aspect of the fibula. So what happens? So you
So
can,
if I misalign a screw, you're saying?
right, right.
So I can see on my X-ray here, it doesn't look too offbeat. But then once I start manipulating the limb itself, I can start to see that my angulation is way off comparison to my other screws. As I
Yeah,
twist and orient this, you can see that I've gone pretty far anterior. One thing that you can do in VR that's it's not probably going to carry over all that well in the video feed is you can none of these structures are actually solid. You have to kind of convince yourself to look in close detail, but you can actually look at the internal structure if you get your face close enough to the bone to see the actual path that that
yeah.
hardware has taken.
Now, your screw, I would say, is acceptable. It's not perfect, it's not great, but if you were to go even more superior, you don't have to do this now,
Mhm.
but if you actually come above and perforate the upper cortex or the most volar cortex of the fibula,
Sure.
you've actually created a stress riser,
Mm,
which means that that can actually fracture the fibula if it goes unrecognized after
up in
surgery.
here.
Right,
Yeah.
exactly.
And we obviously have quite a clean view here in VR that you
We
wouldn't
do, yeah.
necessarily get
Yeah,
based on your exposure during the
yeah,
surgery in real life. So it's possible to get out of whack and not really have your bearings in
yeah,
that case.
yeah.
So at the end of this case, moving forward, like all of our cases in Fracture Lab, there's metrics that you can kind of compare your attempt against.
Right.
And one of the nice things about this is if I pull this out, we'll get a really clean view of this. So I'll keep this out of the body like that. And on the panel here in step 4, I'm able to show and hide the metrics. And what this does is it actually plays an animation of the correct orientation and order based on the author who created the case and what they would do. And obviously, there's many ways to skin a cat, as they say. You could do this case in multiple different ways, but this is one form of comparison you can do versus what you've done and then compare it to an author. And you can play that animation back again and again. And in addition, you'll see that on X-ray, because this is virtual reality, we can do what we want. We've changed the author's colors to be sort of a translucent blue. These colors represent the hardware you did not install, so it's clear to differentiate between your work and the author's. But this gives you an ability to sort of compare and contrast your work versus the accepted author's solution to
Mhm.
the case.
Yeah. That looks great, Mike.
All right. So I think that probably concludes our first foray into the case spotlight. And this is again going to be a freely released training opportunity for anyone that wants it. And all you need to do is go to our website and sign up for the free trial, which you'll automatically be given access to this case and subsequent cases we do in the same format moving forward with other KOLs and key expert surgeons who are going to give insights, just like we're doing today, to really give you some benefit into understanding how to get the most out of these training opportunities and tips and tricks to make sure that you feel comfortable and confident when you go into the OR.
That's great, Mike. Well done.
All right. So, in closing, this is our first foray into our new format of virtual grand rounds, which we're really excited to introduce to the world. And we're really hoping you get a lot of value out of watching these videos, learning from
Right.
them, and then going into VR and practicing it for yourself. Subsequent sessions will be other cases similar to this, but across the body so that you have access to cases time and time again to practice different skills in trauma, in orthopedic trauma, orthopedic surgery, as we flesh out and build out this catalog. Any final comments there, Danny?
That's great, Mike. Thank you so much. I think you did a great job in that simulation. And the beauty of this is it's accessible and available to anybody who wants to use it and get better. And like anything in the world for us personally, in terms of development, whether it be sport, instrument, in this case, surgery, it's it's repetition, it's practice. So this is giving you an opportunity to watch what we did, Mike and I, and go into the virtual operating room and practice these skills. Make the mistakes, do them in this virtual environment, take as many x-rays as you want, drive that skill to a level of expertise. When you go to the operating room, you're not just confident, you're competent and extra skilled because you've done this in the virtual environment. And I think one of the most exciting things for Mike and I is that it's free for anybody who wants it. So if you have a VR headset, just go to our website and you can download it from there.
Yeah, trying to democratize education, making it accessible for everyone. That's really one of the main tenets and
Exactly.
goals of the company. So again, thank you for watching, and until next time, stay tuned, and we'll see you then.
Thanks, everybody.